So it started. So we can, I think, already start. So welcome to today's webinar of Choosing Wisely in Pediatric Practice. My name is Alia Ghazzawi. I'm a pediatric resident from Klagenfurt in Austria, and I'll be your moderator today. For those watching our webinar for the first time and are not familiar with Choosing Wisely, it's an initiative that was spread a few years ago by the American Board of Internal Medicine with the idea to spark the conversation between clinicians and patients regarding the necessity of tests, treatments, and procedures. Over the year, it has spread, and societies like ours, the European Academy of Pediatrics, came up with own lists of procedures and treatments that lack supporting evidence. That's why in today's episode, with the title From Cognitive Bias to Collaborative Decision-Making, we will talk about why clinical decisions are not immune to bias and how assured decision-making can prevent misdiagnosis and overtreatment. And we'll have a case-based insight from a gastroenterological point of view, followed by evidence-based recommendations concerning the prescription of PPIs. We will have time for your questions at the end of the webinar, so please use the question and answer box. And one of our presenters will use WooClap, so please have your phone or second tab ready. So let's start with our first speaker, Dr. Gabriel Brändle, who is a pediatric emergency physician and co-head of the pediatric department of Nyon Hospital in Switzerland. He's a key advocate for choosing wisely in Switzerland and also contributed on a European level. He will give us an overview on what metacognition is and how to detect cognitive bias in decision-making and strategies to promote thoughtful pediatric practice. So the mic is yours.
Thank you very much. So yeah, first of all, I really would like to thank the EAP organizers in the name of the Choosing Wisely working group, because having the opportunity to share our efforts on reducing the use of low-value treatments and unnecessary testing procedures on this platform is really, really appreciated. We also are eagerly waiting for an update regarding the rescheduling of the previously planned webinar on working for child health in Gaza, which was postponed at a very short notice last month. This topic is of utmost importance to us as we consider that caring for children must remain a priority beyond any context. We want also to thank the EAP for the public statement about protecting every child, published just yesterday, and pointing for how peace and political responsibilities are prerequisites for children's health, as they are the most vulnerable victims in any conflict. So as a working group, we sincerely hope the EAP will be able to host this important session in the near future, reaffirming our shared commitment to placing children's well-being above any other considerations. And to serve as a transition, since there was a decision to postpone this meeting, and I'm here to speak about decision-making, let's speak about that, but in a slightly different context. So first of all, I'd like to talk to you about a study that was made with adult doctors. It was one of the biggest studies we did in Switzerland on this subject, more than 3,000 doctors, family medicine doctors, and they had like forced participation, so it was a large recruitment. They served them for 2 years on feedbacks on how they were prescribing antibiotics, how they were compared to other physicians. They get guidelines, they get up-to-date advices, they get a lot of information. It costed a lot of money, taken a lot of work, and guess what? The results were just marginally significant, almost useless. Because making decision is not only about information and knowledge. You have a situation, you need to make a decision, where first thing you'll take the individual risk and benefit balance, of course. Then you have the social benefit risk. And because if you give too much antibiotics, there will be resistance and there are other risks. We'll speak about PPIs, side effects later. And there are a few other details that you might think about. We don't have time to think about everything. That's human. We're not just made this way. That's why we developed what are called heuristics. Heuristics are like small shortcuts of thinking that help us with reflection when we are short on time. Those words, those shortcuts are really, really efficient. I mean, that's what allows us to not to overthink that we have to run when we meet a lion, but they were never designed to practice medicine in such a complicated context. They were never made to understand fine risk balance benefit calculations and those kind of things. This has been widely studied in psychology, but mostly in economics, where decisions and behaviors are really the key of the matter. And I cannot stress enough how this book from Daniel Kahneman, economic Nobel Prize winner, was again changing in the way I understand the decision-making process. So I highly recommend it. And let me begin the presentation with 3 take-home messages. I will not put them in the end. But you have to keep in mind that when we face a decision, when we face a choice, the fear of losing something appears way bigger than the potential gain. The fact that our decision process is widely affected by the order of the kind of information we have. If I give you the same information in a different order, I can make you change your decision at the end. And that's human. We all wired the same way. And the last thing, is that doing hard math like probabilities and magnitudes, it's not something natural for human beings. It's not something that we can understand on an instinctive level. We have to take a lot of time to integrate those elements in our decision process, and it's time consuming and energy consuming. We're not naturally good at that. Then come the sophism of action. When we face a difficult situation, we have a urge to do something, just to act, because it relieves us to do something. And whatever the something is, if we have a situation where we feel the need to act, we think about one action, then we might act even if in the end it can be detrimental. We have this urge to act. Again, it's human, and we'll discuss on how it affected PPI prescription a bit later. So you have to think about what you will do in these situations where you are pushed to do something without thinking too much. The first thing is what's called the bias of mere exposure. That's something that's really well known in the advertisement world. Just the fact that you have been exposed to something makes you develop a kind of attachment to it. Just the fact that you've seen a brand before will make you think higher of it when you face a decision. When you have to choose for a washing product or a soap, you cannot analyze every element of it. You just go for the one that has the more impact on your mind. And the fact that you've been exposed to something, if you heard about something, your brain thinks it's good. And that also works for medication. It also works for treatments. It also works for testing procedures. And you can add to that what is called the availability bias. That's the bias that makes people so afraid of shark attacks, even if they are almost non-existent. Because every time it happens, it has a huge media coverage. So you think about it, you're reminded of it. And in an emergency department, when someone has luckily a really specific diagnostic, something really rare, something really unique, you will see that the other doctors will order more tests looking for this rare disease in the following weeks, just because you saw it happen once. It doesn't increase the real probability to find it, but since you were exposed to it, you think it's important, you think you have to look for it. And again, it's not in the best interest of the patient because rare things are still rare and unique. Another thing that arises and that you can see a lot, it's the fallacy of compromise, or the gray zone fallacy. If you have 2 different opinions on one situation, one doctor saying you should not give antibiotics, the other one saying, okay, you should give 10-day course of antibiotics, then you might think the truth is somewhere in between. then you may order a shorter course, like 5 or 7 days, because you're not going to either one of the extremes, but you never consider that one of the extremes was probably completely wrong. So getting in the middle, it's usually not the best solution. That's pretty much when you have a debate with an infectiologist and an anti-vaxxer, the impression for the public will be that the truth must be somewhere in the middle, which I think we all know it's pretty much not in the middle. And another bias that we face a lot in medicine is that we tend to overestimate the short-term risk. And that means that we are prone to taking long-term occult risks to have the impression, to have the feeling that we are reducing the risk at the right moment right now. That's why it's so hard to fight against the urge to order a brain CT scan for every head trauma, because it's way easier to consider the short-term risk of brain hemorrhage and to forget the long-term risk of leukemia or other radiation-induced cancers. And that's, again, that's normal, that's human. We are driven to recognize and to treat short-term risks, and that's something we should be aware of when we take decisions. And there are so many more other biases. I don't have the time to develop every one of them. There's one more I would like to talk about. It's called the hammer's law, the law of the hammer. The short statement is, if you have a hammer, everything will look like a nail. If you have a small CRP point-of-care testing machine, everything will look like an infection, and you will tend to do more tests just because it's available. If you have one specialty, you will look at every problem with the lens of your specialty. And of course, if you only think about cognitive bias, you will think that every decision is conditioned by cognitive biases. So talking too much about that would also be falling in one cognitive bias. So let's think a bit further, a bit far from that. If you want to change things, if you want to change the way people prescribe, the way they practice medicine, you cannot just go with information. I mean, using an information model would be so nice. It would be enough to write smoking kills on every cigarette pack so people will all stop smoking. Spoiler, it doesn't work. If you want to affect people, you need to get to the emotional level. You get to have good information, of course, and you also have to use what we call nudges. Nudges are small incentives that you can put to change the way people behave. And if you can take these three aspects of the emotional or the process of thinking, then you may have a change. What works, of course, you can use in hospital guidelines. That would be probably the easiest and most authoritative way to change behavior. You can have nudges, as I said. There was a beautiful study in Canada about prescribing less ankle X-rays for sprains, where if you wanted to order an X-ray, you had to answer a series of 5 questions answering the Ottawa rules. So just by making harder or more complicated or longer to prescribe an X-ray, they observe a huge reduction in the overuse of those X-rays. You can also, if you have a lot of time and money and people to do that, have face-to-face educational meetings, but again, addressing informational, emotional, and behavioral aspects. You can help people to better argument, giving communication skills. One thing we hear a lot from doctors is that, yeah, I would love to change the way I prescribe, but my patient won't let me do or not do something. Giving people tools to better negotiate, to better communicate, it's a huge way to improve the impact of those campaigns. And of course, shifting the social norm towards something that will reward the fact that we choose sobriety, we choose not to overtreat, and rewarding those kind of behaviors, that's also an important part of the work. So I'll beg you, keep those elements in mind when you'll hear my colleagues talk about PPI. and think about how you can use those tricks to improve, well, your practice maybe, but how you communicate about this practice with your colleagues later. Thank you very much for listening.
Thank you so much for this overview and these important messages. Next, we have Dr. Alessandra Montemaggi, who is a board-certified pediatrician at the Pediatric Department of Maya Children's Hospital in Florence, Italy, and who is also a member of the EEP Choosing Wisely Strategic Advisory Group. She will talk about psychological bias in decision-making and will also present the clinical case.
Good evening, everyone. Thank you. So I'll try to put into practice what Gabriel just told us about decision making, starting from common, I'd say, case report, something that we can find in our practice. And let's think about this process of decision making. So this is the case of Paolo, a child, a 3-month-old boy. He is, sorry, can you see this? So he is a first pregnancy for his mother and is an IVF pregnancy. The mother had gestational diabetes and delivered at 36 plus 4 weeks. His weight was normal, but he was a small baby, 2.5 kilos. And he was exclusively breastfed for his first months of life. And then he was started on a Formula 1 integration because the mom had the feeling that she had not enough milk. Parents say that over the last month, he started presenting frequent crying fits and also frequent and important regurgitation during or after feeding. And also he presented some arching in despair. Let's have a look at his feeding and sleeping habits. He eats breast milk and an integration with a normal type 1 formula. And how usually he's breastfed while the mother and the child are laying down on the bed because the mom says that it is easier for her to breastfeed in this position, and then he continues with the bottle. And he tends to have breastfeeding and the bottle every 3 hours. Parents says that he regurgitates right after or during the meal, but very often he starts eating again after regurgitation, and he appears to never refuse to be fed. As for sleeping, he usually sleeps on his right side or on his back side on a flat surface. Parents go to a pediatric evaluation because they are worried about this behavior. On clinical evaluation, general conditions are good. Remember, his birth weight was 2.5 kilos, and at pediatric evaluation, now he's 3 months and 3 weeks, his weight is 6 kilos. So the growth in terms of weight is excellent. During clinical observation, he presents one of the crying fits and an abundant milk regurgitation with no blood, no bili. The pediatrician reassures the parents and hastily gives some advices as for position and suggests an anti-reflux formula and plans a checkup after 1 month. So here is a link that I invite you to use using scanning this QR code through your phones to answer some questions and make this presentation interactive with you. So would you do something different from the pediatrician? No, I agree behavioral advices are the first step to manage gastroesophageal reflux in infants. Or yes, parents should be reassured about the baby's good clinical conditions, explain the nature and good prognosis of reflux, giving extensive behavioral advices and a closer follow-up. Or yes, I would reassure the parents about the baby's good clinical condition, and I would prescribe a 2 weeks trial PPIs and a follow-up in 2 weeks to check on growth and responses to PPIs. or yes, I would prescribe anti-reflux formula, and in case symptoms do not improve, I would consider a PPI trial. I'll give you a few seconds to answer. Sorry. So the majority of you answered yes, parents should be reassured about the baby's good clinical conditions, explaining the nature and good prognosis of reflux, giving extensive behavioral advices, and a closer follow-up. And we think this is the right approach. We will discuss better this approach in the further session, especially with a gastroenterologist. What happens next? 2 weeks later, parents continue to be very worried because symptoms persist, although the baby's growth is still very good. So they go to a second pediatrician and he prescribes lansoprazole, 1 milligram per kilo, 1 hour before feeding. He is started on lansoprazole, but another week later, this second pediatrician receives a phone call from the parents because symptoms still persist. And so on a phone call, he suggests to refer the baby to a pediatric gastroenterologist, maybe for further investigation, an endoscopy, a pH monitoring, or an ultrasound. And then I ask you again, what would you do? Would you do something different from the second pediatrician? No. If behavioral advice is failed, it is correct to start medicine, or no, if symptoms persist, it's correct to refer the patient to the GE specialist for further investigations. Yes, in absence of signs of alarm, I would continue to reassure the parents. Or yes, a baby with regurgitation unresponsive to behavioral advices needs instrumental investigations before starting PPIs. So yes, all of you responded correctly. Yes, in absence of alarm signs, I would continue to reassure the parents. In this case, there are not what is called the red flags for GERD. So the baby continues to have a nice growth. He just has these symptoms that might be common. So the best option would be to continue to reassure the parents. Parents go to a third pediatrician because these symptoms still persist and are very worrisome for them. On clinical evaluation, the baby has still a very healthy appearance. Also neurologically, he shows a good head control, he smiles, and in terms of growth, he is now 4 months and 3 weeks, and his weight is 6.9 kilos, so the growth continues to be excellent. This time, a third pediatrician reassures the parents about the good clinical conditions of their baby, plus he informs the parents about the physiological mechanisms behind reflux and regurgitations in infants, which is the immaturity of the stomach, and that this condition has a good prognosis and would disappear over time. Also, he stops the PPIs and spend time to give extensive explanation, such as avoid overfeeding, suggestion on the sleeping on the back, and that regurgitation is not the cause of sudden infant death syndrome. He gives practical advices on daily routine, on cuddles, and also explains that PPI can favor infections. He gives a closer follow-up in 10 days. At this point, parents admit that they are particularly worried about a possible reflux because they have a close relative, which is a 6-year-old cousin with neuromuscular disorder who presented weight loss, anemia, and who's ultimately found to be due to an esophagitis due to a gastroesophageal reflux who wasn't recognized over time and wasn't treated. So they ask to do further investigation to be completely reassured. And again, what would you do in front of this request of parents? Would you refer the patient to a pediatric gastroenterologist for a specialist evaluation, or would you continue to reassure the parents that there are no red flags and that further investigation are not needed, confirming a close follow-up? Or would you continue reassuring the parents and prescribe an abdominal ultrasound and blood exams to make it stronger, this process of reassuring the parents? And yes, we agree that continue reassuring the parents, spending time explaining the nature and spending time and effort in communication would be the optimal option in this case. So I end this presentation with a comment from my colleagues.
Thank you for your presentation. I felt like you want to share something. For those watching, please use the question and answer box so we can answer your questions at the end of our webinar. I can move on to our next speaker, right? Alessandra, is everything? I can move on, right? Alessandra?
Yeah.
You're done, okay, because I was not sure if you're looking for something. Okay. Next, we have Dr. Sandra Trapani, the head of the Pediatric Internal Medical Unit of Myers Children's Hospital in Florence, Italy as well. Her main areas of interest include pediatric rheumatology and gastroenterology, somatoform disorders, and nutritional deficiencies. She will discuss the right or wrong choices in the management of Alessandra's case. So, thank you.
First of all, I would like to thank you for this opportunity. And now I go on. After what Alessandra told us, it's time to stop blaming gastroesophageal reflux and to verify how pediatricians worldwide actually behave in terms of PPI use. And this slide presents the results of an Italian survey investigating the approach of 100 general pediatricians to the use of PPI in children and adolescents. And the study found that proton pump inhibitors are significantly overprescribed, with rates approaching 80%, as you can see. And on the other side of the world, a study conducted at a tertiary pediatric hospital in Melbourne, in Australia, analyzed the prescription of PPI and H2 receptor antagonists as well. And they reached that they have a similar conclusions, because also in Australia, PPI were prescribed without an appropriate indication in 78% of cases. And furthermore, which is surprisingly, they were prescribed in most instances from specialists. Indeed, more than a decade ago, pediatricians from American Academy of Pediatrics were among the first to take a stand on GER medication, including them in the top 5 list of their Choosing Wisely recommendations. And as you can see, they stress again that pediatricians do not treat gastroesophageal reflux routinely, as you can see. And just a couple of years later, all the major American pediatrics societies, as American Academy of Pediatrics, Society of Hospital Medicine, and American Gastroenterological Association, agreed and reiterate not only the recommendation against using PPI in so-called epi-spitters, but also against the routine use of antacid, and in addition, they recommended using only the lowest effective dose when the use is actually deemed necessary. And at the same time, again in Europe, specifically here in Italy, the Cultural Association of Pediatricians, which promptly joined the Choosing Wisely movement, strongly included among its recommendation a detailed statement on the inappropriateness of prescribing all the aforementioned drugs, PPI, anti-H2RA, and proteinetics in children with physiological gastroesophageal reflux, which does not impair growth. And also, a few years later, the section of perinatal pediatrics of the American Academy of Pediatrics, in their 2021 report on 5 things physicians should question, stressed that even in preterm infants, anti-reflux medications should not be routinely used, as they may be associated with several adverse physiological effects, as well as necrotizing enterocolitis, infection, and possibly intraventricular hemorrhage and mortality. And the Canadians, long-time leaders in Choosing Wisely movement, align with this position. And in most recent update of their Choosing Wisely recommendation, they continue to emphasize the inappropriateness of prescribing PPI for reflux in infants. So we have now to face our position. These are obviously our 10 recommendations for physicians, and also from the European Choosing Wisely study group. We see that the number 10 is again repeating the same message. And at this point, we would like to reiterate the definition of reflux stated by the North American Society and the European one. And as we can see, GER is the passage of gastric content into the esophagus with or without regurgitation, vomiting. And it is a physiological event, as you certainly know. It occurs several times daily. It is brief, lasting less than 3 minutes, is postprandial, asymptomatic, and without warning signs. But the most important thing is to define and clearly define which is the definition of GERD. And the same authors, the same societies in the same journal specify that the GERD is when GER leads to troublesome symptoms that affect daily functioning and or complications. But it's not so easy to diagnose this condition because, as we know, reported symptoms of infant GERD vary widely and may include excessive crying, back arching, regurgitation, and irritability. And as you know, these symptoms occur in many, many babies with or without GERD, making a definitive diagnosis challenging. Therefore, the degree of parents' consent is often the factor driving for a medical diagnosis, which is easier for them to accept. And as you know, to distinguish GER from GERD, a detailed medical history and a thorough physical examination are really essential in infant evaluation. Therefore, for the pediatrician, it is crucial to know the presence or absence of alarm signs, which can guide us in distinguishing between GER, and GERD and choose the right management approach. In this slide are summarized the symptoms and signs that may be associated with gastroesophageal reflux disease in children and infants. And I would like to highlight that discomfort, irritability, but almost failure to thrive and feeding refusal are the principal general symptoms, as well as anemia as general signs. And now we can summarize that finally, based on expert opinion, the American and the European gastroenterology societies have put forward the following recommendation: not to use H2RA or PPI for treatment of crying distress in otherwise healthy infants, not to use the same drugs for treatment of visible regurgitation in otherwise healthy infants, and not to use H2RAs or PPI in patients with extraesophageal symptoms like cough or wheezing, except in the presence of typical GERD symptoms or diagnostic testing, really suggestive of GER. Now, in my last slide, I would like to take some conclusions. The step for the pediatrician facing an infant with reflux are, first of all, to explain to the parents that the GER is common, especially in the first months, and that most babies outgrow these issues without any complication. Highlight the cause, as we already listened, the incomplete maturation of the gastrointestinal system is responsible for this. And give practical advices as small changes in routine, such as keeping the baby upright for a while during or after feeding, reducing the milk amount, or taking breaks during feeding. And reassure the parents that GER improves with time, and many babies with GER improves as they grow. But we have to monitor very careful warning signs. And in presence of difficulty breathing, weight loss, or inconsolable crying suggests the need for a new medical assessment and probably to refer the baby to pediatric gastroenterologists. I'm lasting my talk with a philosophical point of view, but this is a very important decision we have to take, looking for adherence, choosing wisely. The best approach is to not medicalize what is physiological. Thank you for the attention.
Thank you so much for this beautiful presentation, and also the clear indications for using PPIs and the strong message at the end. Please don't forget to share your questions in the questions and answer box so we can talk about your questions after the next speaker that I'd like to present. Dr. Sara Renzo. She's a pediatric gastroenterologist from the same hospital, from the Maya Children's Hospital in Florence, Italy, with specific expertise in endoscopy and management of gastrointestinal disorders, including inflammatory bowel disease and celiac disease. She will give us a presentation on the use of PPIs in pediatrics.
Yes, good evening. First of all, I would like to thank the organizer for the kind invitation. I'm going to tell you about the use and misuse of proton pump inhibitors. As Sandra mentioned before, European guidelines clearly indicated to the pediatrics when to refer the young patients to the specialist, to the gastroenterologist. But first of all, let me remind you the work of the Impressionist master Monet. He drew many times the Rouen Cathedral, and it shows us that we can see the same thing in different lights. So proton pump inhibitors can have a clear indication, but they can be used without a valid clinical indication, and they present a dark side too. So we know, and we have seen before, that it is not right to use PPI in otherwise healthy infants, because PPIs do not improve crying or irritability compared to placebo. And in this nice paper, they underline that this misuse of PPIs deprives the pediatrician of their educational and guiding role, that of anticipating and helping families understand and tolerate the psychological manifestation in infancy. It undermines the mother's sense of security, leaving her vulnerable to fear of hypothetical disease, and it may lead to a form of dependency on PPIs. So, as I said before, the best approach is to avoid medicalizing physiological conditions. And here are another fields where we should not use PPIs, and these are the isolated respiratory symptoms, for example, cough. And let me show you also the dark side, because the use of PPI may lead to mild but frequent adverse effects. For example, headache, nausea, and regurgitation too, and also diarrhea and abdominal pain. In literature, there are warnings about the use of PPI when they are not indicated, because they can be associated with obesity or a high risk of asthma. Or also, I find it very interesting, there is a link between the infant acid suppression and the development of eosinophilic esophagitis. It's very surprising. And they can expose our young patients to fractures. But we can see the light at the end of the path, because we can use this PPI, for example, as a PPI test. I'm thinking about young patients, but older than 8 years, that can clearly tell us symptoms that can let us keep in mind about reflux. For example, heartburn, retrosternal pain, and epigastric pain. We can, in this kind of patient, do a PPI trial, typically between 2 and 4 weeks. If there is a response followed by a relapse, we should perform an upper endoscopy to check what is going on. And another thing is very important to keep in mind, that there is a group of patients and a high risk group that can have a GRD. I'm thinking about children with cerebral palsy, patients operated for esophageal atresia, obese individuals, patients with cystic fibrosis, patients operated for esophageal achalasia, and individuals with hiatal hernia, lung transplant recipients, and in those with a family history of GRD or Barrett's esophagus. And now the light, because here there are some clear indication, of course, and we should think about when we have a patient with an erosive esophagitis, a peptic ulcer and gastritis, and a known Helicobacter pylori gastritis or ulcers, and all these, the rare but possible situation in which there is a gastric hypersecretion disorders. In these cases, PPI therapies should last at least 8 weeks. And let me remind you also a new statement in the new guidelines, European guidelines about eosinophilic esophagitis. PPI can induce remission in a proportion of pediatric patients with EOE. But we should use esomeprazole at the higher dosage. You can see 1-2 milligram kilos per day. This is an anti-inflammatory dosage. In the other condition, esomeprazole have proven to be highly effective even when administered at low dosage. And now a little window in a peculiar situation. We should think about that as a prophylaxis when our patients should use NSAIDs or steroids. While there is no clear evidence supporting this practice in pediatric patients, it is well established in adult population. So when we think about children, we should use PPIs as prophylaxis, for example, in that kind of patients who needs a higher dosage of NSAIDs, for example, in Ghazzawi syndrome, and when we should use steroids at the high dosage, for example, in case of use of methylprednisolone boluses. And now here there are my conclusions. So proton pump inhibitors are highly effective in the treatment of acid-related disorders. Do not use in infant for irritability, crying, or night awakenings. Do not use for isolated respiratory symptoms. PPI trial in older children with heartburn or epic acid pain is possible. And for chronic use, diagnostic evaluation is necessary, test and retest. And chronic use in high-risk children should be considered, and be aware of potential and long-term adverse effects. And thank you.
Thank you so much for the presentation. So for those watching, if you have any questions, please use the question and answer box. Maybe in the meantime, maybe you, Alessandra, could you tell us what happened to your patients at the end? Because you said the parents, they insisted on checking the child for this disorder, and did it happen, or what happened to the child?
No, actually, finally, the communication was key to find a trust relationship between doctors and parents. And so communication, close follow-up, continuous reassuring of the parents, and obviously following up the patient. The condition went progressively improving as it happens with growth. So there wasn't need to do anything else.
Thank you so much. And as a mom of a 9-month-old, now soon 10-month-old, I remember the first time after birth, we also had problems with the feeding. And I remember in Austria we have a midwife. We have midwives that take care of you at the beginning of your after the delivery, and she told me yes, she will come again after I've seen an osteopath, because that's probably a problem with this. So I'm not sure how it is in your countries, but osteopathy is not paid by the insurance, and to expect everyone just to pay for it is also it's a interesting approach. And Sandra also said we should go to the physiological shouldn't be treated, right? So did you with the choosing wisely, or or does your hospital also work together with other professions? Because if there is a proper, if it's properly taking care of parents at the beginning, and they are sure, okay, my child is taken care of and it's normally developing, then they might not show up. But is there any, that's a question for all of you, is there any approach also with other professions on choosing wisely together? And how does it work? Or also with GPs, for example, because I remember often that parents said, okay, if I don't get antibiotics from you, then I'll go to my doctor. He always gives me antibiotics. So yeah, that would be interesting for me. And maybe Gabriel, you can answer first, and we can have an open discussion.
For now, the structure of the Choosing Wisely movement, it's really based on every specialty does list for its own specialty. There is still really few interprofessional interactions. We have in Switzerland, for example, physical therapists had one list, nurses have one list, but again, those are more focused on adult medicine. So yeah, a next step would be to reach out to the Pediatric Physical Therapists Association, but I don't know how many of them are there in Switzerland, or if they have a European association to reach out. So that could be a next step, of course.
And also, I don't know, like maybe also with midwives, I don't know how it works in other countries. Some countries, they offer the care of midwives after birth. And when you go to the pediatrician for like the checkups, sometimes there is not so much time for like examining the child and like then answering all the questions. It's like there's something in Italy that you're aware of, that you also interact with other professions? Yeah, Alessandra.
So as for the interaction with midwives is not, so what happens here is that every kid's newborn has a pediatrician, a general pediatrician, which is like the family doctor. And there is not a connection with the midwives, although there is a practice of like private midwives that often say something different from the pediatrician, and many times it is confusing for parents, especially parents of a newborn, a first child, as in the case that we presented today. The first months of life are a very difficult time for parents. So it is a time where parents are in particular need to be reassured, to have someone to address their questions, not to be confused, to get a clear message. And so also to get many of the principles of the choosing wisely, to correctly address every problem that they encounter, to be correctly reassured and not to do inappropriate exams, evaluations, etc. But it is a field where there is, of course, a lot to do. Either doctors and all the physical therapists, midwives, the gynae also. So a lot of work to do.
Okay. Okay. Do you have anything else to add? Anyone wants to add another thought? Because otherwise, also from from the people watching, I thank you for the presenters. It was an excellent webinar according to one person. And then I would close the webinar. And if there are any further questions, that you can also reach out to the presenters and directly contact them. And I want to thank everyone for participating in the webinar, and also for our presenters for the wonderful presentations. Concerning the next webinars, we're now on a little holiday break. So in September, there will be like the webinars will continue. And I would like just to use the last minutes to also promote free projects by the European Academy of Pediatrics. So on the one hand, there is the EP Leadership Academy that will take place in September in Leipzig. It's emerging pediatric leaders and young professionals in medical advocacy. So you can still sign up if you're interested in. It's a really great opportunity, and it's taking place for the first time. And another two projects. So on the one hand, the EP Master Course and Congress that will take place from the 16th till the 19th of October in Warsaw, in Poland, with a lot of great key speakers and presentations. And prior to this Congress, there will be the first exchange program by the Young European Academy of Pediatrics expedition. It will take place in the Children's Monash Hospital in Warsaw, so you can follow pediatricians of the hospital and take place in this exchange. Will take place from the 13th to the 15th of October. So thank you all, and I wish you a good afternoon and see you after the summer. Bye-bye.
Thank you. Bye.
Bye-bye. Thank you.